another meeting of the Green Mountain Care Board, and we have a couple of sets of minutes for approval. The minutes of the meeting of January 26th and the minutes of the meeting of February 2nd. We have a motion for...
Move to approve January 22nd and February 2nd minutes.
That would be, can I amend your motion?
Sure.
January 26th.
January 26th.
Thank you.
Second.
Do I have a second? Any discussion? All those in favor?
Aye.
Okay, thanks. So today is very exciting for the members of the Nancy Turnbull fan club. Which includes Georgia and me at least.
It'll be everyone by the end of the meeting.
Yeah, and by the end of the meeting you'll all be members. Nancy is a friend from Massachusetts who is Associate Dean at the Harvard School of Public Health, but has had a number of positions over the years that relate directly to a number of different aspects of our charge and sort of health reform generally. She knows everything there is to know about Massachusetts healthcare reform and has been deeply embedded in their reform process and currently has served since the beginning of the Commonwealth Health Insurance Connector as a member of that board, as a consumer representative on the board. Earlier in her career, she was deputy commissioner, first deputy commissioner and deputy commissioner, I didn't know there was such a thing, of health policy at the Massachusetts Division of Insurance. So she also has a lot of knowledge of how to do good insurance regulation. She's on the board of a number of other healthcare organizations, including Commonwealth Care Alliance, which is an organization that I know the folks here in Vermont who are looking at the dual eligible project have been in touch with. So she knows about some stuff about that as well. She's generally just brilliant and usually entertaining. So,
Wow.
Nancy, thanks a lot for.
Thanks.
Yeah. Yeah, we don't have our name tags. Sorry, Janet pointed that out to me. So we're going to have everybody say their names so Nancy knows who we are.
Great. I'm Alan Ramsey. I'm a family doctor from and formerly a member of the Department of Family Medicine at the college.
Do you want to say a little bit about your background?
Past Secretary of Human Services in varied other parts of the checkered career.
You know me.
I'm Karen Hine. I have been executive officer at the IOM and worked in the U.S. Senate Finance Committee and other divergent roles for a position.
Hi, my name's Al Gobey, and I'm a restaurant guy.
And I know you, so good. Well, thank you for inviting me to come and talk with you today. And I'm a little intimidated by the introduction since one of the things you asked me to talk about was rate review, and then you said I was entertaining, so that seems somewhat oxymoronic.
If anyone can do it, you can.
Okay, well, I didn't know that was my charge, but and I'm really happy to have the chance to come and talk with you. And I come from the state. Massachusetts has really been the most under the microscope, I think nationally, for its our efforts to expand health coverage over the last 6 years. And when we first passed our law, people thought we were just those weirdos from Massachusetts doing something strange again that would have no relevance for anyone else in the country. And lo and behold, I think we had quite a lot of effect on the national health reform laws. So we're very happy to pass the microscope to Vermont. And because I think, as you know better than I do, all eyes are really very much on Vermont now, as you really, I think, have, in my view, and I think the views of most knowledgeable observers, the most interesting and the most exciting health reform initiative going on in the entire country, one which promises to have extraordinary national impact. And I think far beyond what we've done in Massachusetts, where our focus has really been, and I think we're proud of having made significant successes in expanding health coverage, but the goals that you've taken on are much broader than what we've done, having to do with affordability, quality of care, and everything else. So, so it's very nice to have been invited, and I'm looking forward to the conversation with you. And it's always nice to see dear colleagues from Massachusetts, Anya and Georgia, and Lindsay Tucker, I know, is involved in here and very respected and admired in our state. And I think
If there's anyone else we can poach, let us know.
yeah, well, my inbox is crowded up with job descriptions. So we're on the beat, trying to find you some other people to come up here. And I'll tell them that there actually is still winter in New England, because that's the first icy parking lot I've actually seen since last year in Massachusetts. So that might attract some people. So Georgia asked if I would talk about two very disparate topics. One is the issue of rate review, and which will be informed by my experience not only as somebody who for many years had responsibility at the Division of Insurance Massachusetts for setting rates and approving rates, but also somebody who's participated in a number of rate proceedings and rate hearings in other states, usually on behalf of consumers and consumer representatives. So I'll talk a little bit about that. And then I was also asked to give some reflections on serving on the Connector Board, our exchange in Massachusetts. We are also a very public board, and what we have found to be some of the challenges and some of the things we've done to kind of make that very public process work, I think, fairly successfully. So I'm not here to give you advice. One of the things, I'm not from Vermont. I know how irritating and aggravating it is to have people come from another state and tell you what to do, because many people have been doing that in Massachusetts. So I'm not here to do that. If I have anything that is helpful to you as you go forward doing your work in Vermont, I'll be delighted, but no recommendations. So let me talk first about rate review. And I know that you had a really excellent presentation back in December by Oliver Wyman, which is posted on the website, and which I looked at. So that presentation really was very technical and sort of concerned the sort of technical aspects of what's the process used to set rates and what goes into rates. I'm going to not be technical at all. I'm not an actuary by training. I want to take the discussion of rate review kind of up to a much more public policy oriented standpoint and talk a little bit about, from a public policy perspective, what are some of the goals of rate review? What are some of the challenges of reviewing and approving rates? What are some of what I view as the sort of unmet opportunities in reviewing rates? And then talk a little bit about what a couple of other states are doing in rate review. And when I came here, one of the things I said to George as we were walking over was that I very much hoped that you would invite Chris Kohler, who's the Health Insurance Commissioner from Rhode Island, to come up and talk to you. And not surprising, you were way ahead of me, and he's already on your agenda. Rhode Island is by far the state in the country that's doing, in my view, the most forward-thinking work on rate review. So I stole a few slides from Chris, but it'd be much better to hear it from him directly. I think a lot of what they're doing in Rhode Island could be very helpful in informing your role in terms of rate review. And I'm assuming this is...
The elephants upstairs.
The elephant?
You guys see?
What is upstairs?
A museum.
A museum?
Yeah.
Oh, good. It's probably not an actuarial museum. They're making too much noise. But so let me start with just kind of a perspective on why is rate review needed. And I've got some slides, and I hope, I know you're a lively group, so please interrupt or argue or whatever. I teach at Harvard, and students there are very rude and very argumentative, so you can be both or neither. But okay, so why is there rate review? Because rate reviews existed in most states for quite a long time, and as I'll talk about, I think it's largely been quite ineffectual, more to do with how it's been implemented and some of the statutory standards. But the traditional rationale, which has existed really, I would say, until the last few years, has been that there needs to be rate review for consumer protection reasons. You know, kind of a classic economic argument that there's an inequality in power and information between insurance companies and consumers. And so it's focused usually on people who buy in the individual market, sometimes people who buy in the small group market, but really out of a theory that large employers or large purchasers have power, they can take care of themselves, but individuals don't have any power. And so therefore there needs to be some oversight by government, mainly to prevent gouging is really kind of the classic thing. So that left to their own devices, there's a risk that insurance companies will just charge as much as they possibly can, and somebody needs to exercise some constraint over them. More recently, however, there's an increasing focus, and this is certainly the case in Vermont from your new rate review standards, on adding a second dimension to rate review, which is really to try to focus on affordability of coverage. So the traditional rate review, and I'll talk about this a little bit more, is really focused on, it's been very technical. You know, are the projections that people are making right? Do the numbers add up? You know, kind of dueling actuaries. But there hasn't been much attention on, is the result of that process a premium that people can actually afford? It's been a much more technical conversation. So this focus on affordability now, and I think you're one of the only states, maybe with the exception of Rhode Island, there might be another or two, who actually has the word affordability or affordable in your rate review standards. And this is a huge improvement and a great advance. This is just, you won't find that in the rate review standards in Massachusetts, you won't find them in virtually any other state. I mean, I think that grows out of a growing realization, which we've had for a very long time, of how important health insurance is for people getting access to care, for people having financial protection against the costs of expensive health care, and also for health itself. So as you think about the standards and the process that you're going to put in place here in Vermont, I think it's great that you have this standard of affordability, and I hope that you really focus on that and try to flesh it out. The other growing realization about the power of rate review is that the critical role it can play in educating the public. Generally, rate review in most states, you could not pay consumers to actually sit through the process. It's really boring, it's really arcane, it's very, very difficult to understand unless you are yourself kind of technically trained. But the opportunity that you and other states now have through your new standards and the requirements in the federal statute is really to try to think about how can you use the process of rate review to both educate but also get consumers in particular more smarter about why is health insurance so expensive? Why are costs going up? What are the range of strategies that we could employ, you can employ as a state and others could employ, and that's just never been a focus. And it's really critically important because we know we have this immense divide between policymakers and the public in the reasons why they think health insurance costs are going up, what strategies are available. I think if you polled many Americans, they think if we would just reduce the compensation of health insurance executives and whack their administrative costs a little bit, we would have reached nirvana and we'd all have affordable health insurance. And I don't think that's actually overly simplistic in some ways. So to think about putting in place a process that would actually help elucidate for people in an understandable way, well, why are costs going up and what are some of the things? So I hope as you think about your rate review process, I mean, I know that this is embedded in your standards, that you'll do more than just making the actual material that insurers file available to the public, but really think about how do you make that into some understandable and digestible format for people to pay that educational role. So critical, important role for rate review from a consumer perspective.
So Nancy, I don't want to take you
Yeah.
off course now, but
Yeah.
I do want to at some point come back to this concept of affordability because
Okay.
it is very
Yeah.
central to what we're doing,
Okay.
and operationalizing it is a
Okay.
real challenge.
Okay, so
I'd
I'm
love
happy
to get your thoughts
to
about
talk to
how
you
we
about
can
that
do
too.
that.
Okay. The second thing I would argue is that rate review is not only important for consumers, it's actually very useful for health plans. And now health plans hate regulations. Members of any industry typically hate it. But I think it actually can work in ways that's beneficial for health plans. Now they hate it in addition to the reasons why businesses often hate regulation. As an industry, they're quite risk averse. I mean, that's in the nature of being an insurer. Their goal always is to try to produce rates that are adequate, to build up reserves, That's usually enabled by regulators who historically have had a focus on solvency. I mean, if you're a regulator, the thing you probably, at least I used to lay awake at night worrying the most about was, please don't let an insurance company go bankrupt on my watch. And so what flows from that is you really want to be sure that the rates are adequate. There's just a primary focus on that. In addition, I think health insurers, and I don't know well the health insurers here, so you might have a different group, but if you look at the industry as a whole, they don't tend to be very introspective. Their focus usually tends to be not on examining themselves as much as how are we performing in relation to other insurers. I would say this is kind of sibling rivalry. If you talk to individual health plans, the conversation will usually be, well, how are we doing compared to that company, or but it's not ever like, how could we make a contribution to kind of the system working better. And I don't see that with any malice towards insurers. I suspect probably if you talk to members of many industries, you'd find the same introspection. The other thing that is often a characteristic of health insurers is that because the proportion of the premium dollar that goes to pay their expenses and their profit margin is here in Vermont, it's about 10 cents on the dollar. They think that, well, we're only 10 cents on the dollar, so therefore there's really not that much we can do, and we don't have much control over the other 90 cents. And this often leads, particularly in the rate review process, into a syndrome of a lot of attention on the administrative expenses and trends in the profit margin, but a really an examination of the medical expenses. Insurers also don't have many incentives to collaborate. And I think, and I'll talk a little bit more about this in a couple minutes, that this is an area where you can really advance the performance of the industry by identifying ways here in Vermont where collaboration instead of competition among health insurers would further what you're doing. And you can think, and particularly those of you who are clinicians, just imagine a world in which every health insurer didn't have its own contracts, its own provider payment system, its own claim form, its own. So I think that those are not things which are easy for individual health insurers to do by themselves. But they are things which often, if you get them in a quiet room or a dark basement or a bar, they will tell you, oh, we wish someone could do this better for us. And then finally, I suspect this is a growing problem in Vermont. It certainly is in every other state. As a result of market forces and other forces over the last 10 or 15 years, there's really been a growing geographical dominance of certain hospitals and providers. So in most parts of Massachusetts and in almost any other state I've worked in, we really don't have a lot of competition among hospital systems anymore, and not much competition among physician groups. And so the traditional dynamic that we've relied upon to some extent to try to keep health insurance more affordable has been competition between health insurers and providers. But in fact, that isn't the world we live in anymore. And so insurers really need, I think, both public pressure but also public support in a world that looks very different than the world in which they grew up, to really, I would say, have more resolve, be braver, be tougher, be more creative, be more innovative in terms of dealing with the market forces. And this is, again, something that they really can't do by themselves. They both need support to do that, to kind of take on the political consequences and other consequences of trying to do that. But at least in our state, they've really needed a push too. We've had a lot of attention on health insurer rates in Massachusetts over the last couple of years, led by our governor. And there's a new relationship developing between providers and health insurers that I'm quite convinced would not have happened without using the rate process in our state to try to
Nancy?
strengthen those. Yes.
When you talk about this 10 cent on the dollar syndrome,
Yeah.
and that being the administrative costs, and
Yeah.
then you say the insurer needs to kind of carve down on the medical expenses, you know what that makes me think is claims denial, where we're trying to move them towards quality.
Yep.
And so what are your thoughts about that transition? So you're going to because that is part of the criteria now we're using. It's affordability, access, and
Yep.
quality.
Yep.
So how do you make behavioral change like that? Okay, so you're going to carve down on medical expenses. You're not just going to deny claims. You are going to be part of the quality.
Well, or you're going to adopt new methods of paying. You're going to pay to support care management, nurse case managers at physician offices. We're going to work collectively on trying to create a system where more of the premium dollar goes to primary care than it does. We're going to work with you on making systematic changes and moving away from fee-for-service or medicine towards other.
All the things we're doing with the providers.
Yeah,
Yeah.
which is great, but I think
Yeah.
you need to bring the, at the end of the day, you need to have the insurers on board as well. And I think those are probably things which most of them would support doing, but it's very hard when you're in the, I'll say, the rat race a little bit of competing against each other, and you never want to be the insurer that does the very innovative thing, because that may create problems with some of your accounts or some of your members. And I mean, I think the landscape is littered, particularly about 10 years ago, with the carcasses, maybe not the carcasses, but the remembrances of insurers who tried to do something innovative, and they found no one was behind them because the employers were getting pushback from members. So, and I think that's the kind of support that you need to think about doing.
Nancy, before you
yes.
go on, just going back to why is rate review needed for consumers?
Yep.
And your excellent point about widening the discussion with people so they understand what are the factors behind the rising costs. So
Yep.
how did you do that? Or what suggestions would you make for public engagement around these types of issues, which aren't on their minds, and also the way they think about them needs a reframe?
Yeah, so I mean, I think that there's there are things that you can do of making the information that's in rate filings more accessible to people. There's some good examples in states which try to produce simple comparative information across health insurers that looks at what proportion of the premium dollars going to different categories of expenses, and if you look at individual rate increases, what are the components of rates that are actually going up. We've done a lot of work in Massachusetts, and I can show you a couple of slides that show that the thing that's driving premium rates in Massachusetts is provider prices, and increases in provider prices. So we've had very public hearings that have been very well attended, trying to, where both our Attorney General and our state government agencies have produced information that I think is quite accessible to people. It's gotten a lot of press coverage, and it's fueled a different conversation about why we need to focus on payment reform and other things. So I think that there are some good templates, and I'm sure you all can develop good, but getting the information out both in a more digestible fashion, but also working with advocacy organizations to be your tools for that as well. I mean, where Georgia used to work at Healthcare for All in our state's done some wonderful work on trying to get consumer groups and the organizations that they work with. I attended a couple weeks ago a wonderful meeting. We have a great group that's been very important in Massachusetts in our coverage expansion efforts, and now has turned to cost control, which is called the Greater Boston Interfaith Organization. So it's an organization that's comprised of churches, synagogues, mosques, and they work on a very grassroots level with individual churches, and they've been doing a series of meetings with individual churches and members of churches trying to explain why healthcare costs are going up. So I participated in one of those. We had like 200 people at one of the churches in Boston, where we gave presentations on why costs were going up, and we got the best questions I've actually ever been asked in a meeting. So I think there's a lot of both work that you all can do as a board, and then working in partnership with other organizations as well. People, I mean, you know this from, I always use my sisters and brothers-in-law as the example, but they have no idea why costs are going up, so.
Need those materials.
Yeah, no, I mean, GBIO has some great,
Yeah.
has some really, really good stuff. Just a couple things, and I won't belabor these, but as I said, traditional rate review really hasn't worked very well. And you're much better positioned in Vermont than in many other states. But the kind of standard until recently has been in many states they don't do any rate review. In a lot of states the scope of the review is very limited, so maybe they look only at individual, maybe they look only at Blue Cross, maybe they have what's called a file and use policy, so insurers have to file their rates, but unless the regulators do something. Very narrow standards for review, that's why I was very excited to look at your statute. Usually focusing around this concept of, are the rates reasonable? And so the reasonable is usually, are they reasonable in relation to what they're projecting they're going to have to pay out, but nothing about affordability, and become, kind of really an actuarial conversation. A common problem in many states, and I hope this is not the case in Vermont, is overwhelmed regulators who have neither the resources nor often the expertise to really take on the health plan. So often, health insurance is just one of many lines of business they have to regulate. Sometimes they have banking and securities. Actuarial expertise is very, very hard to get. I always say in my next life I'm going to come back as a public interest actuary, because I think it'd be a fun and pretty lucrative living probably. But I'm always outgunned. Often advocates don't have the expertise or the resources that they need to participate actively in the process. So I think finding ways that you can make that expertise available to your consumer groups here. A big bugaboo of mine often is that there's often a separation between rate review and review of the solvency of companies. So rate review just proceeds here, but there's never really any look at, is it really necessary for the health insurers to have a rate increase? This is kind of fueled by this concern about solvency generally. So really never taking a step back, the financial review people and the rate review people might not even ever talk to each other. That's a common pathology at insurance departments. And so this issue of not just is it reasonable in terms of its projections, but do they actually need, based on their financial solvency. And then another thing which I think you could really address in your work is usually rate reviews done on an insurer by insurer basis, and nobody tries to take a step back and compare what's going on across insurers. And often there you find very interesting trends which can inform what you do. So you'll find one company, their prescription drug costs are going up a lot, another company, their hospital payments are going up, and really it's sort of getting a sense of what's going on dynamically across the system.
Have you seen good examples of that?
Yeah, the stuff that Chris is doing in Rhode Island is very good. I think we have some good examples in Massachusetts, and Minnesota also has really good. I think that's some of the most powerful things to beginning to start asking questions about how is the ecosystem working. We have some good things we've been doing, starting to do at the connector as well. So as I said, you're much better positioned to do rate review than virtually any other state by virtue of a few things. One is you have a broader range of rates that are subject to review. It looks in your statute like virtually any policies subject to review. Your review standards are better. I think there may be one other state that has affordability, quality, access in their statute. So often a constraint that rate regulators have is they don't have the legal authority within their statute to be looking at many of these issues. They're constrained by, are the rates unreasonable, excessive, unfairly discriminatory? That's usually it. I'm intrigued your statute says they can be neither unjust nor unfair, which that's an interesting ethical conversation you need to have about what the exact difference between those two words is, but that's you have a very strong base of existing regulation. You have higher medical expense ratios than anywhere else, and I think you're aided by having insurers. I don't think it's any coincidence that the states that are doing the more aggressive rate regulation have a manageable number of insurers. Imagine you're in a state that has dozens and dozens of insurers, and it would be very, very hard to do effective rate regulation there. So you have some areas that you can focus on: affordability and what's the effect of increasing premiums on enrollment, and equity of premium structure. Very few states look at profit margins and contribution to profits by line of business, which I'd commend to you to do if you're not already doing. It's often very illuminating in terms of rates. But what I want to suggest to you is, while I think that there are a variety of different standards that you can use that are in your statute that you can use, that you actually have the opportunity to move beyond just doing better individual rate review, which I think you can do, but you really can, build, and I think your law contemplates this, putting in place a process that develops a structure for more systematic and system-wide rate review. And this would really very much put you in the vanguard of states. The only other state really that's doing this in any reasonable way is Rhode Island. And if you're going to do that, you basically, I think there are three things you have to believe. One, you have to believe that actually health plans have the ability to do something about medical costs. And just not buy that we're only 10%, we can't do very much.
Or I would say, I think in our case, because we have a broad authority that goes beyond health
Yep,
insurance,
yep.
we also can look at the impact of
Mhm.
the provider.
So that's great. And I think that's a common dilemma in many other states. There's just not an existing structure. So one part of government looks at this part, so that's great. You need to think that there's an appropriate role for government to play in terms of putting pressure and also supporting health insurers to do this, both in dealing with the sibling rivalry problem, but also the fear that they appropriately have about backlash from competitors or backlash from the public. And then you need to think that an openness and transparency about these issues is going to lead to better public policy making. So here are some of the kinds of things that a few other states are doing in terms of taking a system-wide approach to rate review. So there are a couple of states that are really trying to say, instead of looking at rates on an insurer by individual basis, we're going to take a step back and define priorities for the health insurance sector as a whole. So what are the things that we think we should be moving health insurers collectively as a group to doing? And the states that are doing that have tried to identify areas where they think insurers actually have some control over those activities. So there's some effective role that health insurers can play in moving the system in that direction. That they're evidence-based, so that there's evidence that if we do those things, we affect the measures of health system performance that we care about. So affordability or quality or improving health. That they're developed through a public process, so you're obviously perfectly positioned to do that. And I think they've also tried to identify areas where collaboration instead of competition is necessary. So things which individual health plans can't do by themselves, and that really require health plans working together in some organized way to do. So they try to define priorities, and then they try to identify specific and measurable requirements to impose on health plans. So they identify specifically what do health insurers, what do you want them to do? They identify processes so that they can assess whether health plans are doing those things and report publicly on process. And then they have structures where there are penalties for the health plans if they don't perform. And those penalties are generally that these system-wide performance measures are one factor that's taken into account deciding whether health plans get premium rate increases or not. So I think, to me, that's the kind of structure that you want to try to move towards. And there are only a few examples, and I'm glad that Chris is going to come and talk to you, because I think Rhode Island. So in Massachusetts, we had, although we haven't had for the last 10 years. We had a requirement in our rate review statute, and this applied only to Blue Cross, that Blue Cross, before it could get a rate increase, had to demonstrate that it was doing effective cost containment and quality improvement. So we had rate hearings, and we would spend literally a month examining in detail what Blue Cross was doing. And if we found, based on testimony of experts and others, that there were things that Blue Cross wasn't doing that could have been effective, we could deny their rates. And when we had this statutory authority, in the past, we used that very effectively to both get Blue Cross to do a number of things that they otherwise wouldn't have done, and to suppress rates. Now, that authority was taken away through the political process, because it, depending on what you think, it either suppressed rates too much or it was very effective, and Blue Cross didn't respond to it. So that's one standard that you could adopt.
Well, you can kind of get yourself in a box with that one.
Yeah, you can. You can.
If you're not controlling costs, then your rates can't go up.
That's
but
right.
your rates might be going up because you're not
Controlling costs, yeah.
And
Well,
then you've got the solvency argument.
Yeah, exactly.
Yeah, you do.
It's a tough one.
It is a tough one. So one of the tricks here always is, if you're going to be a tough regulator, you have to be able to deliver to controlling costs, because that is how you get into a solvency bind. And Blue Cross would make the argument, I think, in our state, that when the statute existed in the first year or two, it was helpful, but then it just was used in a political way. As a person who wrote the rate decisions, I would deny that, but I would say that they didn't do everything that they could have done. Other things which people are doing, and these 5 are from Rhode Island. So Rhode Island has been very focused on increasing the proportion of premium that goes to primary care. So they have identified over the next 5 years what proportion of premiums they want to see health insurers in Rhode Island devote to primary care. And so there's a graph. Their goals by 2014, they want to get to about 11% of premium, and they started about 5%. And so they have been working with the health plans as a whole about how we're going to get to our goal of 11%, which they set by looking at what proportion of premiums or what proportion of premiums are devoted to primary care in very well-run integrated organizations like the Geisinger Health Plan or Kaiser Health Plan or Group Health in Washington.
Would there be any pushback? I mean, I'm a family doctor, and this sounds like
sounds
the best
great.
thing since sliced bread to me. But on the other hand, we've got specialty bargaining groups that that could and very powerful special interests. What has been the impact?
I mean, that's exactly the dynamic that's been set up in Rhode Island, and there's one other state that's looking at doing this, which is one of the requirements is that increase the percentage of primary care without that having an inflationary effect. Yeah, so the hospitals in particular don't like it, because if you're going to do this, it's a reallocation. So now we have the health plans and the state pitted against the hospitals. I think this has led in Rhode Island to more and more examination of hospital rates of payment to try to find the opportunities for where those can be reduced. I mean, Chris can tell you much more entertaining and perhaps cautionary tales about doing this, but you're exactly right. That's exactly the dynamic that's been set off. But if we're going to move to a more sustainable, affordable, better functioning healthcare system, it's all going to be about reallocation. So they've also been trying to strengthen chronic care management by imposing requirements on health plans as a group and getting them to work in a coordinated way to support patient-centered medical home initiatives, to pay uniform rates and in a uniform fashion for medical home initiatives. They have required health plans to include in their premiums specific incentives to provider groups to help them fund and adopt electronic health records, gotten them to agree to reform a provider payment. And they've actually gone one step further, which they've been doing a lot of work, and I don't know in Vermont if these are data that you have. I think in Massachusetts and in Rhode Island and in a couple of other states, there's been a big focus on trying to use data to understand relative rates of payment of hospitals. So these are some data from Rhode Island where they, on a case mix adjusted basis, looked at how well or badly are hospitals paid relative to statewide averages. And you can see here they have huge disparity in Rhode Island.
Well, I grew up in South County, so I'm really sad.
Yeah, well, no, I mean, and you can look anywhere where this analysis has been done, they find disparities on a case mix adjusted basis on the order of 50% to 100%. I saw one state where it's 200%. And so this is part of the reallocation argument, right? We need to have a much better understanding of how have the forces in the market advantaged and disadvantaged some provider systems. And so as a result of this analysis in Rhode Island, they've adopted specific standards which are imposed upon the health plans in terms of provider contracting. In Massachusetts, when we did a similar analysis, so we found, these are just some data that, 55% of premium increases for Blue Cross over this time period were unit price increases. So the major factor that was fueling premium increases for Blue Cross, and this was consistent across all of our large payers, was unit price. There was some case mix, there was some utilization, but price is really where it's at.
Nancy, before you
Yeah,
go on,
sure.
just going back to the one that compared Intermountain
Yeah,
and
mhm.
with England, which has twice the percentage
Yeah,
of the
Yeah.
25 versus the 11.
yeah.
Can you just say a word about that for the U.S.? I mean, what should the goal be? That's pretty high, 25%.
Yeah, I mean, I don't know what the goal here should be, and I have to say I grew up in England. And I bet they don't use England on the slide anymore. I mean, I don't know what it should be. I don't know what the magic numbers, and you can look at health systems around the world and you'll have widely disparate. I think we can say it should be more than it is now. I don't know what it is. Do you know what it is in Vermont?
I don't know what it is as a percentage of premium. We have looked at number of primary care per population, and I can't remember what the numbers were.
It's in around 30%, maybe even 27%, seems like.
Of the premium?
No, of the total providers in the state.
Oh,
that are-
yeah.
But we've got a big medical center too,
Yeah.
so it's.
I think I think a great starting point would be, where are you?
Yeah.
So they pick, I don't think they're
I don't know
not
if we could-
suggesting, nor would it ever be politically palatable to go to 25%. But I think they picked the goal of 11% in a really thoughtful way by reference to, if we look at very high performing integrated practices. An integrated health plan, so group health of Puget Sound, the Geisinger Clinic, Intermountain, what's the proportion that they're spending on primary care? And what they found is it's a lot more than it is in England, but it's somewhere between 10 and 15%. So that, if you look at the performance of those organizations in terms of their ability to control costs, they're high quality organizations. Looking at what proportion do they spend on primary care and what has that enabled in terms of system performance, I think seemed like a good goal. So they said 11%. They did this in a very consensus building public process with wide input from many, many different types of stakeholders. So I can tell you, when Rhode Island found it was only about 5%, they were stunned. They didn't know that it was that low. So I think a good starting point would be, what is it in Vermont? In Massachusetts, it's about 7%, but I think we should move to 12 or 15%. But that's where I'd start. So we found the same. This is a slide in Massachusetts that looks at variation in hospital payments on a case mix adjusted basis. So each of these bars is an individual hospital, and we're bigger than Rhode Island, so it's harder to read. But we found twofold variation. The real outlier is Nantucket Cottage Hospital, which for a variety of reasons gets paid a lot. But we found the same types of variation. We found this variation was and this is work which our Attorney General did, it's not based on quality, it's not based on case mix, it's not based on whether they're teaching hospitals or not teaching hospitals, it's not based on whether they have a lot of Medicaid patients, a lot of uninsured patients, and it's not based on underlying costs. What the analysis in our state found is it all has to do with market dominance. So the hospitals that have high rates of payment have either geographical monopolies or geographical dominance, or they have what economists would call brand monopolies. And in our state, that's the Mass General and the Brigham and Women's, or Children's Hospital, which essentially has a brand monopoly. So I've seen similar data in about 4 or 5 other states. It all tells the same story. So we have some hospitals that get paid very, very well, and some hospitals that don't get paid well. We did the same thing for physician practices, for primary care groups. So these were data looking at assigning individual patients back to their primary care group, and then looking at differences in what's the total medical expenses within medical groups, and these are case mix adjusted as well, health status adjusted. And so we found huge disparities, even bigger than, so about 40%, 50%. Interestingly enough, there's a lot of attention in our state on trying to move towards global payment, and a lot of belief that if we just adopt global payment, that will, and Anya knows this well because she sat through a lot of it. The red bars on this are physician practices that are paid on a global payment basis. So there's actually no systematic relationship to lower costs and global payment. So some of these also are really big practices that get a lot of. So,
And I think you'll find part of what we've been talking about here is that the global payment to the practice may not mean
right.
A particular type of payment
That's
to
right.
individual providers.
Yeah,
So that
yeah. This is the kind of, you need to look beyond the contracting organization.
Can you elaborate on that? You mean the way the providers pay
the
is different than
providers
the way the
underneath
hospitals
that
pay?
global payment may still be paid on a volume basis.
They might not even know they're at risk.
Oh, yeah.
They don't
Right.
even know they're at risk.
No, they don't know at risk.
Yeah.
Where I go, my physician practice is paid on a global payment basis, but my particular practitioner is salaried, so she doesn't face any. She has somebody in the office next door to her who gets paid on a session basis. She has somebody else who gets paid on a relative value unit basis. So it's not even necessarily consistent from. So in our state, because of these disparities, our governor's filed a payment reform proposal, which we'll see if it meets with success in the legislature or not, which is really going to impose requirements within our rate review process to actually look at individual provider contracts and look at the results of the provider contracts, and to try to tie increases in rates of payment to providers to increases in the gross state product, and to look at disparities. So I think a lot of attention on how do we link the rate review process to the provider review process too. So just a couple final thoughts, and we've touched on those. So I think that there's a lot going on. I'm delighted that Chris is going to come because he's thought better and more deeply about these things than others. I do really think rate review can be an effective force for helping to moderate premiums. It's an important tool. It's not sufficient, and it's only one tool. I think it can be particularly helpful in putting pressure on health insurers to negotiate more aggressively with providers. One problem with it, and I know that this has been a conversation here too, is if you put a lot of pressure on regulated rates, there's always the danger that costs, if they're not actually controlled, will be shifted onto the unregulated rates. And this is often a tension between regulating small employer rates or individual rates, that they'll be shifted on there. So it argues for a system in which you look at rates broadly across and don't just look at only sections of the market. There's a lot of downside to regulation to it. It can often become a very political process. I once approved a rate increase for a line of business and had 65 people doing a sit-in outside my office, which now I look back on 20 years later was pretty entertaining, actually. I wish there was the kind of, but there's always the temptation when you become the entity that's responsible for approving the rate, to not want to approve rate. We talked about how if you suppress rates but don't have successful efforts to control the underlying costs, that can be a problem in terms of solvency. And at the end of the day, it's an indirect way to try to change the behavior of consumers or providers. But I think you really have the opportunity here to lead the way among states in terms of really thinking about what effective role can rate review play in terms of higher quality and more affordability. And the problem always with being in the vanguard is you have a lot of other folks who have led the way, but I think that there are some. Yep.
Is there any way to penalize a payer other than limiting the rate increase that they're able to, through some sort of public engagement? Is there any other influence other than just their rate increase for a badly performing, for a payer that doesn't take into account affordability, accessibility, and quality?
So other things that you can do?
Yeah, how do you put in here penalize the payer, impose penalties for failure to perform, and incorporate those as part of the annual rate review process. That seems to me there's just one thing.
Yeah,
and
I think it's
the rate increase.
Yeah, I think it is a fairly
Is there-
blunt instrument.
Yeah, okay.
Although things like, you've talked about requiring certain payments, and we've done that here through the blueprint,
Yeah.
on a voluntary basis, but you could require conceivably that you use particular types of payment methodologies, that you pay particular amounts. So regardless of what happens in the rate request venue, you can do other things.
Well, and I think some of those things, and this is sort of evidence-based piece of this, if there are structural or process things that we have evidence actually can be effective over time at helping to control costs.
Mm-hmm.
Like community health team.
Right.
I'm sorry?
A community health team.
Well, that's what I'm talking about.
Yeah.
Rhode Island has required that. We've
Yeah.
done that through our blueprint.
Or, we know that they can be very effective to have, instead of armies of nurses and case managers on the telephone, to actually embed people within primary care practices themselves. I think that you can try to come up with these process and system interventions and require them as one component of the rate review process. But I think at the end of the day, the decision that you make on the rates is the decision that you make on the rates. But I think there's a lot of ability to get the attention of health insurers and help them do things which they might want to do or they're just a little bit reluctant to do through the rate process. But that is ultimately, I think, the tool that you have. I think other penalties, you can make them stop writing insurance. That creates its own problem.
De-license.
We only have three. So.
De-license, particularly in a state where you don't have large numbers of insurers. That's
not really feasible.
That's
So
usually
I'd
not
like to go back to
feasible.
this issue of affordability, and you allude to it again in your standards for
Yeah.
review. As you know, I'm married to an economist who tells me there is no such thing as affordability. You either buy it or you don't, and sort of establishing a standard for what is affordable across the population is very hard. How have you wrestled with that in Massachusetts?
So in Massachusetts, we have a standard of affordability, as you know. So we, and that's one of the things that the Connector Board has had to do. So we've had an individual mandate in place in Massachusetts since 2007, which obligates adults to buy insurance if it's affordable, is what our statute says, or pay penalties through our state tax system. So it's very similar to the structure that's in the federal health reform law. Since we predated the federal health reform law, which actually has a standard of affordability that Congress has now decided on, we had to come up with a standard of affordability as a group. So we have at each income level and family configuration in Massachusetts, we have a dollar amount which we as a board of the connector has, which we've decided is affordable. And so it ranges for an individual from if your income is below 150% of poverty, which is about, what, $15,000. We think that paying nothing is affordable. And we have public programs, either Medicaid or our subsidized program, which are available to the vast majority of people at no premium. And then the affordability schedule goes up, so at the highest income levels, I wish I brought it, because it's about, for an individual, did you have it, George, by any chance, in your head?
Was $108?
Well, it goes for the subsidized. I think it's up to about $250 at about 450% of poverty. But you know, we have a schedule, and
But if you think about that, that's a schedule for what an individual pays.
Yeah.
Then there's you're filling in the gap between that and whatever the rate of increase in the total cost of the premium is. So you have there's sort of an interplay between what you decide the individual should pay and how much you let the premium go up. You could be keeping it affordable for the individual, but then what's a reasonable rate of growth in premiums overall, or the system overall?
Well, so this is an issue that we're grappling with in terms of our payment reform legislation, which will, we hope have some overall measures of system affordability. And so the measures that people are talking about are moving towards a system where we link increases in premium and increases in state health spending to the increase in gross state product in the state. I think most of the economists say gross state product may be a little bit aggressive. And so the versions of the law, the draft law that I've seen, have gross state product plus a couple percentage points, or maybe a phased down approach. So we say, at the moment we're probably gross state product plus 5%. But that ultimately we'd like to move to a system where healthcare costs don't grow any more rapidly than the overall goods and services in the state. So I think that's what the economists that are working on that bill say, and that seems reasonable.
And have
to
you
me.
seen good calculations of how, how to figure out what's the right glide path essentially on that? Or does it still feel like you're just sort of
I think it's
picking a
kind
number?
of, it's like, where do you think you want to get to and over how many years, and then you do the math. I don't think there's any great...
Science.
Yeah, well, the economists will say it's science, but always dismal. I don't think there's any magic. A part of it depends on where do you start, where do you need to get to, and how disruptive do you want to be to the system as you glide. And I suspect in Massachusetts what we'll decide, because healthcare is here, it's the biggest part of the economy, it's the only part that's growing. There's a lot of concern about not doing anything that's going to really be incredibly disruptive. We'll probably glide more slowly than some people want to. But I think a link to gross state product makes a lot of sense to me.
Thanks. Al?
Is there anything in that math that accounts for technology or takes it out, and then, in other words, pay raises and capital expenditures on plant and all those things? It's easy to argue that should follow some metric of a state GDP type thing. But with technology, it comes in fits and starts, and how do you factor that in?
I think the discussions we're having are that technology kind of development just occurs underneath. And if we want to be able as a state to afford proliferation of technology, we're going to have to find savings other places. So it's an argument that I'm sure that the hospitals will make and continue to make, but we're not thinking about doing it on any kind of segmented basis. We're really thinking we want to move towards a system where we have overall system goals and some enforcement mechanism of the goals, but have individual decisions below. Now, that may not be where we get to, and we may not end up linking it to gross state product, but that's the discussion at the moment.
Any other questions on this section of the presentation? All right.
So then the second and completely unrelated thing was just to talk a little bit about our board, which I have to say, knowing that you're all spending so many days a week working and meeting a lot, we're kind of a slacker board. But so let me just tell you a little bit about our board and sort of some of the methods that we've used, which are pretty obvious ones in terms of functioning in a very public space. So let me give you just a little bit of background. So we are our state's insurance exchange. So we were created on our 2006 law. We have both policymaking and programmatic responsibilities. So we have had to make the decision in Massachusetts, the decisions about implementing our individual mandate. So that has included deciding what the minimum benefits that people must buy to comply with our mandate are, developing that affordability schedule. So what's the amount of income which people at different income levels have to pay, which we deem as affordable. So if they have coverage that's available to them at that price, they either have to buy it or they have to pay a tax penalty.
And are you having to reconcile that now with the federal scheme?
Yes, we will. So our affordability schedule and our subsidy schedule are more generous in the sense that we require a much lower percentage of income than the federal schedule does. So the decision we're going to have to make is, do we adopt the federal schedule or do we try to wrap around the federal schedule in terms of subsidies? So the federal schedule will require lower income people to pay a much higher proportion of income than we have in Massachusetts. And so we'll have to decide, do we want to, at state expense, continue our subsidies or not? So, and we're in the process of trying to figure that out. And then we also, our laws, the federal law allows people to get waivers from the individual mandate. So even if they have something affordable, there's a waiver process where they can say, well, it may be affordable on average, but I have particular financial circumstances that make insurance not affordable for us. So we administer that waiver process. And then we also run 2 programs of insurance. One, which we call Commonwealth Care, which is a program for people who have incomes 300% or below, but they're not eligible for the Medicaid program, and they don't have employer-sponsored coverage. So this will morph under the federal law into the tax credits for people up to 400% of poverty. And then we're also, as your exchange will be, we're also a place where people can come and buy unsubsidized coverage. So we've developed benefit packages, the precious metals one that are now embedded into the federal law, the gold, silver, bronze, and we have young adults. And then we've had a significant role in terms of implementing health reform and outreach and marketing and things. So that's what we do. So we are what in Massachusetts is quasi-public authority. So we're a governmental entity, and we're exempt from certain parts of certain laws that apply to other state agencies. The one that gets the most attention is staff who work for the connector are not subject to the state's salary scale. So we've been able to pay, sorry, Georgia, whatever. And so we're governed by, we have an 11-person board.
Are you also exempt from the procurement rules?
We're not exempt from procurement. No, we're not. So we have to go through the same state procurement process. So we have an 11-person board, and 4 members of the board are ex officio. And so we're chaired by the chief budget officer in our state, the Secretary of Administration and Finance. A very interesting choice. You would normally, I think in most states, expect the Secretary of Health and Human Services. But we've had, and this, while I think it was done for political reasons, which I won't bore you with, and personal reasons, has ended up actually being wonderful for us because we have the person who makes all the decisions on the state budget heading up us up. And I am convinced that over time that's meant that we've done much better in the budget process than we were had he not, we would have done had he not been on the table. Then we have the Medicaid director, the insurance commissioner, and then the head of the agency in our state that buys benefits for retirees and state employees. And so those people serve, just by virtue of being in those positions. And then we have people who are appointed by the governor, and they are a health actuary, a health economist, and a representative of small business. And just over the last 6 months, our statute was changed to add a broker to our board. So this came about, I think, because brokers felt as if a number of the policies we were adopting, that they weren't adequately represented. So this was the first. I mean, in some ways, we didn't have health plans, we didn't have brokers, and now we have a broker. And then there are 3 of us who are appointed by the Attorney General. So as Anya said, I sit in the consumer seat. And then there's a representative of labor unions and a representative of health and welfare trust funds. So there are 11 of us. Those of us who are appointed, we have 3-year staggered terms. And we've gone through a change in administration. So we've had kind of different political mix on the board as well. But people, because they have 3-year terms, some people have been on the board the entire time and some people have cycled on and off. So our board meetings, as your board meetings are, our board meetings are public. We generally meet monthly. In the early days of reform, we met more often than that, but we generally have a monthly meeting. We, depending on the issues that we're debating, sometimes we have, 300 people there. In the first 3 years, it's died down a little bit. It was like being at a press conference. So we would have, like a dozen people from the press. There'd be like press microphones hanging over, very, very well attended and very public. People would come and they would blog and tweet and do other things, live blog our meetings. So we have, I think, the same kind of rule that you do. So no more than 3 of us are allowed to meet together at any time, or else it constitutes a public meeting. And so a small minority of the board. And then there's been intense media interest. So this is unlike, I've been on a number of public boards before, but not ones that have been so scrutinized, so well attended, and particularly in the early days of reform as we were making decisions about very, very contentious and novel issues to do with affordability and benefit packages and things, a lot of attention. So developing methods where we would work effectively as a board, very important. And I have to say it's the most fun board I've been on, and I think we have kind of gelled over the years. So even though we're very disparate in kind of political views and personalities and professional training, we've come together pretty well. But it's been hard to figure out exactly how we do that since we can't all get together. Mm-hmm. So the kinds of things that are typical on other boards I've been on, where no one is watching, and you can get together, just aren't available to us. So just a few things that we've done, which are pretty obvious things to do, but I think have worked well. One is, I think all of us who are on the board have spent a lot of time getting to know the other members of the board one-on-one. And in the early years of the board, that actually took quite a bit of time and attention. And particularly because we were often really far apart on substantive issues. Not that we're not still far apart sometimes on issues, but really getting together and getting to know one another. Now, some of us had long-standing relationships, as some of you may too. I mean, I've been on boards with a couple of the people over the last 20 years or so, but that was not the case for everyone, so that's been important. Our statute lets us get together for social activities.
That's specifically in the statute?
Yes.
We'd never leave the bar.
Yeah, really.
Funding.
Yeah, well, so.
Wait a minute, we're still in session. We can, what's that, Bill?
So. Let's go fix that.
Thank you. We'll call it the long trail.
So we're allowed to, we're allowed to have I'm not sure if it's a statutory thing, but our law permits social lunches. So what we tend to do is we have a board retreat once a year, because our board is not as intense as yours. So one of the agenda items always on our social lunch is to have a really candid conversation about how we're doing as a board. And it's the kind of conversation and formal process that boards, other types of boards generally go through about board effectiveness. And those have been incredibly important, just in kind of airing all kinds of different issues about that. So I would say, whatever work you can do that's permissible, just to build trust and relationships is very, very important. We developed on our board from the very beginning, and I think it was informed by the politics of what we were doing, a process of wanting to have consensus on every single vote we took. And we did that, I think, largely informed by we thought we were making really difficult and high-profile decisions, and that we had a law which was controversial, and that unless we could all collectively reach consensus on issues, that could threaten the sort of solidarity and support for the law. So this became a very, very, and continues to be, our mode of operation. We've had only one vote over 6 years that wasn't unanimous. And it's just a really important core operating principle at the moment. So it's one which takes a lot of work, depending on the issue to get to, but it's been very important. And I think all of us realized really early on that, I've been on other boards where I've sat in a particular seat, and boards that function much more by interest group representation. So you represent consumers, and therefore you always vote the consumer position, even if other people don't agree with you. And just because our board is bigger than your board and we have a lot of different interests, it's pretty clear immediately that you'd lose a lot if you voted narrow interest groups. So the consensus, I think, both for the support and success of a law were important. It's just become the way we operate now.
And how do you build that? One-on-one, or
Yeah,
the executive director goes around?
Well, so this is the next thing. So one-on-one is helpful. Sometimes we do 2-on-1 or 3-on-1 or 2-on-1 to do that. And we have, unlike some boards, we have a very solid consumer block. So the union person, the consumer, and the health and welfare trust fund, we vote as a block. It's not, we just do because we always agree. And that's actually helped us in terms of having a stronger consumer voice. We use the staff all the time as the intermediary between us. And so our executive director spends, I don't know what proportion of his time he spends dealing with the board, but it's a lot. And so, and we've developed a policy of, I've been on some boards where you feel as if the executive director is basically trying not to tell you things. And we have developed and maintained over several years, as a board, we want to know more rather than less, so tell us. These are the issues we deal with, and the ones that you deal with are even more complicated. So we process things one-on-one if we can, and we actively use the executive director as our vehicle for helping to forge compromise on issues. We really very much, because particularly in the early days when we were taking really, any word you said in a meeting would appear in the Boston Globe headline. Line things up beforehand on votes. So we didn't have any votes where, on important things where we didn't know how people were voting. And we delayed some votes just to continue to work on consensus. And I think we have a really good relationship between the executive director and the board members, where everyone views each other as resources. And so I've been on boards where you're sometimes not viewed as having important things to bring to the table, and that's simply not the case. But it's very, very intensive for the executive director to have to do that kind of intermediation. But and then we have we have a variety of standing committees, and then we have formed, and I think this has been very effective on particularly contentious issues or really highly technical issues. We use subcommittees a lot. So we have some standing subcommittees, but on the affordability schedule was one, which was where we knew there was going to be a lot of disagreement, so I had a standing committee on that. Developing the benefit standards, we had a standing committee. We have a special working group at the moment on the Affordable Care Act compliance.
And those are open meetings as well.
Yeah, those are open meetings, and we think really carefully, and the executive director does a good job about in trying to make sure that the committees represent the diversity of opinion on the boards. So. Our health economist is on every committee because he always has.
Because he has to be.
Because he has to be, because
that's
he always
what he
has
does.
different opinions. And then one thing that we've used effectively as well is to try to use outside people to help forge consensus on issues too. So different people on the board have certain organizations or types of groups which they have strong relationships with. So there's some triangulation that we do there too. And I think that's an important role for outside groups, and in our state, the advocacy groups in particular have been really, really important in that. So, so I think the openness of a public board, can be a challenge, but I think it's extraordinarily important to kind of building public confidence in what you're doing and support. And I think it imposes, and I'm sure you all feel this, a kind of higher standard of responsibility and accountability than you have when you get to talk about things behind closed doors. But I think it leads to much better policy making at the end. But you do have to work it, and find. And I think on all boards, they're the people who have expertise that you don't have, and over time you build trust in the recommendations that they make, and you don't feel like you have to be an expert on everything. I mean, that's just good board work.
How do you keep up to date with each other? The subgroups help in terms of multidisciplinary views on things, but how do you just simply know what everybody else is doing?
So the executive director does that a lot. So one of the things we do, and again, since we meet only once a month, we have there's a board call with the executive director and each member of the board in the days leading up to the board meeting. And one of the things that he now knows over time is what are the particular hot buttons of particular board members. But so I can say, well, how's X, Y, and Z feeling about this? And then, or he'll say, X, Y, and Z is not feeling at the same place you are. You should really give them a call. So we do a lot of that before board meetings as well. And ongoing. I mean, I have lunch I have a weekly conversation with a couple of the people on the board, and then we have regular check-ins before board meetings. And I'll call people and before I'm not quite sure what I think about this. What do you think? So we do a lot of that as well.
Yeah.
Are there any providers on the board? Any
No.
positions? Or,
No.
are these paid board positions?
No. We get our social lunch once a year.
I vote we don't do the social thing.
Except on boats.
Yeah, no. So I mean, it's quite different from the structure of your board.
Yep.
People spend enormous amounts of time. I mean, obviously not the amount of time that you all are
But
spending.
it's a big investment, right?
No, it's a huge investment.
Still?
Well, I think it definitely has had its ebbs and flows. I would say the first 3 years were really intense.
Mm-hmm.
And now that we're gearing up to implement the federal reform, it's getting intense again. And there are periods where it's more intense than others. So we go through a re-procurement process with our health plans every year.
How are you, I know you have a committee that you form, but this is just my opinion, it's not the board's opinion, but it seems like the federal Affordable Care Act and then things we've done at the state level, it's very hard for the average citizen to understand what's coming from where and why, and
Yeah.
and you created a new thing, and now you're running into the ACA, and how do you reach out to the public to educate them? Do you do that? How does that work?
Well, we certainly did reach out to the public and educate a lot when our law was first passed.
Who did that?
So we contracted with communication firms. We gave
Really?
We gave,
How
yeah,
logical, very logical.
yeah,
I asked that question.
yeah.
My phone number.
We gave
Did she
grants.
know,
We gave grants to community organizations. We had
The Massachusetts Connector Board,
yes.
I'm not bright, procured PR help
Yeah, we did.
and reached out to the state of Massachusetts.
We did.
Can you?
I know
Tom,
there's
can you-
something here that I'm
Do you
not.
have a Republican governor?
Can you
When,
take
when
that?
At
we
the
had
time.
a Republican governor, we did.
Can
Yeah.
you
gotta talk
take
to
that one
someone then.
snippet and pull it off?
We've gotten some grief about this. We tried to do the same.
We're struggling with how to reach out without
Oh,
appearing.
No, you have to. Oh,
Without
we.
being spin
Without having a
doctors.
Yeah, without
propaganda
appearing
machine.
as if we're
Right, it's a
spinning
department.
information.
Oh,
Department
we
of
did.
Propaganda.
Oh, we continue to have. We just voted on it last month. We just renewed our contract with our. Particularly on a lot of the things that we were doing. Oh, we did focus groups and market research and all kinds of things.
And how beneficial was that?
Oh, well, extraordinarily beneficial.
Really?
Yeah.
Could you have done it without it?
No, we couldn't have done it. I'll look right into the camera.
Thank
No,
you.
we couldn't have done it.
You're
without
catching
it.
on. Can I get an amen? Are you with me?
Just to be clear, though, there is some distinction, I think, to be made between the policy work and outreach around that and the kind of outreach that they've done around their programmatic responsibilities, because a lot of what, I think you've done both, but
Oh,
a
yeah,
lot
we've
of
done-
what you've done is the outreach around enrolling people in
So
coverage. And
we've done both, but I mean, a good example was, and again, we have focused on coverage. So we know that it's particularly difficult to get young people to buy health insurance, and particularly difficult to get young men to buy health insurance. So,
so
one
they
of the
co-opted the Red Sox.
when we co-opted the Red Sox, and we
You got the
happened to-
Red Sox?
Yeah, we have a relationship with the Red Sox.
I can't even get an envelope. Keep going.
Oh yeah, and it was very helpful that the Red Sox won the World Series in 2007. So that gives like extra. Oh yeah, we have public service announcements by Red Sox players and all kinds of things. Now I myself am a Dodgers fan, so I didn't expect that.
I'm sorry.
Would
Voted against.
yeah,
What?
I usually don't admit it publicly.
You can up here.
No.
Everyone's like, "What's the Dodgers?"
Yeah. But so we one of the things we did is we hired a firm to do a lot of focus groups with young men, young uninsured men, to understand what would it take for them to buy insurance. And I'm a public health person, I see the world through rose-colored glasses, and I thought, oh, all we have to do is explain to the young men. Now there's insurance available to them, and it's affordable.
Come to where I work.
No, then I sat behind the mirror and listened to 35 young men who were
Yeah.
uninsured talk about it, and they all knew the individual mandate existed. They all knew how much it was going to cost. They all had done the math, and they weren't going to. And so then we found 3 things would convince them potentially to buy insurance. One is they had absolutely no idea how much it would cost them if they had an emergency room visit or got ill, and they were kind of shocked by that. Then the second thing is they actually cared about preventive care, which is kind of contrary to all the literature, but and so if we explained to them that the policies had preventive care, that got them interested. And the third is they actually cared what their mothers thought, which I have to say, as the parent of a teenager, I've seen no evidence of that in my household at all. But so
They
so
don't
then we,
show it in your house.
that's right, they don't. And I have a daughter, so that's a little bit different. But So we did a whole series of advertising and thing around Mother's Day and other things. So yeah, it's been incredibly helpful.
Are you crying on the inside?
Yeah, I'm just thinking about the depiction of young people, and actually studies have shown that this thing about invulnerability and all that, it's just as true of adults
Yes,
as it is
right.
of young
Yeah.
people.
Oh, no, and I think, but young people do have a 30% rate of uninsurance.
Yes,
Um,
indeed. So we got
Part
to
of which
look
is
beyond.
related to the fact that they tend to
Yeah.
be lower income as well. So, well, we have awful ads we did of young people falling off
bicycle.
ladders and lying on the ground, like having had a bike accident and other things. But these were all developed with.
What is your outreach and education or communication budget like? Just generally ballpark.
It has waxed and waned over the course of, and I don't have the numbers off the top of my head, but I can easily share them with. But in the early days, we spent millions of dollars.
And there is.
I'm sorry, what?
Millions.
And
Millions.
there is some
Well-
of that kind of spending built into the exchange. So they are planning to do some focus groups, and I don't know what all, but we can get details of that just around it.
It's very, very important outreach in the moment.
One of the biggest subjects that's kind of coming to light right now is building this exchange, and you've built one.
Yep.
And how did it go? Was it, seamless? Tons of problems? What do you see for a state that has never had one and needs to have one by fall of 2013?
I think our exchange has generally worked very well. We got it up and running very quickly, building off of the infrastructure of the Medicaid program initially. The biggest issue that we've had and challenge that we've had is it's been very difficult to get small employers to buy coverage through the exchange. So we have a significant proportion of the individual market and a very successful program of subsidized coverage for people who are eligible for it. It's been much more difficult to figure out, sort of what's the value proposition for small employers. We have many different intermediaries through which small employers can buy coverage, and active brokers, and so I think some of the challenge has been related to the fact that our dominant health insurer has not wanted people to buy coverage through the exchange, and so until recently we haven't had a contract with them for small employers.
So does your board, you also have a provision down there where somebody's got the responsibility to determine whether a particular plan meets your standards?
That's us, yeah,
That's you?
that's us.
So how do you do it with the small employers?
So this is for the purposes of the individual mandate. So we,
Right.
so the individual mandate goes to the individual. So there are no requirements imposed upon employers.
Okay.
But there's pressure indirectly through the individual mandate, because if
So
I have to.
you do it by not plan, but by individual.
By individual, so.
And that must, how do you do that? I
Well,
mean,
so the way that it works is if you have, so we've adopted minimum standards. And so for the purposes of our individual mandate, adults in Massachusetts have to have coverage that meet the minimum standards. So I have coverage every year around tax time. I get a form from my health insurance company
okay.
that says you're insured, you've been insured for the entire year, and your coverage meets the minimum benefit standards. And then I attach that to my tax return, showing evidence that I was insured for the entire year.
So it's the insurer who certifies?
That's right,
Okay.
yeah. And so there are some people, but not very many people, who have insurance. Oh, is this the break?
We play music at 2:30. At 2:30, it's part of the tradition in Vermont.
It's a lot more fun than our meetings.
That's how we build trust.
That's good, excellent. These are
The
very
dance
important.
break.
Fun. I didn't know if you were going to dance together.
We dance on the inside.
But that's helpful, I understand.
That's the way it works.
Yeah.
Yeah.
So one of our statutory requirements also has to do with approval of workforce policy.
Workforce policy.
Workforce.
Yeah.
And we know, everyone predicts, and we know that healthcare reform is a job engine. It will produce jobs, and it did in Massachusetts.
Yep.
If you compare Massachusetts' growth in healthcare industry jobs to the national,
Yep.
it is quite, a percentage point above national over the last 4 years. But it appears that, just from, this was in the New England Journal, or one of, that most of that is in administrative jobs. And, tell me, in terms of our decisions about approving workforce, we certainly would prefer more of them be in healthcare giving jobs.
Yeah, yeah.
So, what are your thoughts about that?
I'm familiar with the article.
Yeah.
From the New England Journal. I think a lot of us are scratching our heads about it because
Yeah.
it doesn't seem to comport with the experience of colleagues we talk to in clinical settings or generally. Not to be overly academic, but I think there's some issues with the database.
Mhm.
Who wrote it?
Peter Bierhaus
Yeah.
at Vanderbilt, and I'm forgetting two other authors. It's in the New England Journal last year.
And what was the data set?
I'm not forgetting.
I'll give you the article.
Gruber has, John Gruber, who's the health
Yep.
economist who's on our board, has, he says it's well done within the data, but he doesn't, he thinks there's some
Because
methodology
when I see that
flaws
you
with
put a
it.
broker on the connector board,
Yeah.
and knowing that administrative,
Mm-hmm.
are we just hiring lots more people to sell insurance within the exchange?
Yeah.
Well,
So the legislature in its wisdom put the broker on the connector board. He's a very nice guy. That would not have been my decision. I think that, we have very few people actually buying through the exchange, so I don't think it's been a boom for brokers at all. In fact, we've had a lot of opposition to our exchange
Okay.
from brokers. One of the things we've done is we've cut broker commissions quite significantly.
You've
So
cut them? You've cut them?
Cut them. So I think one of the reasons why we now have a broker on the board is because of the power of the brokers in feeling as if we were making decisions which were not necessarily ones which they supported. So.
And there's a distinction to be drawn, at least between the administration's proposal here and the way the Massachusetts connector is structured. Currently, if the bill passes the way it is, the small group market 50 and under would go entirely into the exchange as opposed to it being a choice.
That's what's being proposed here?
Yes.
I think that's a wonderful idea myself. I think there are a whole bunch of reasons why it makes a lot of sense for very small groups to buy exclusively through the exchange. And so that's something that we're thinking about in Massachusetts. I think politically it's probably not possible. There's also a proposal to make individuals buy through the exchange as well. And at least one of the things that's going to happen to our exchange is we're going to lose quite a few of our subsidized members when federal reform goes in, because there are a number of people who we currently insure who are now going to be eligible for Medicaid.
Right,
And it's likely we're going to do a basic health plan.
right.
So one of our challenges is going to be how do we continue to
Keep it
maintain
viable.
a viable exchange that has any market clout. So we're going to look to probably other parts of the market too. We're looking actively at student health insurance. So students in our state have to buy health insurance, and that's a lot of people.
Could you elaborate on why you think it's a good idea for everyone 50 and under to be in the exchange?
I think that there are parts of the market that are very disadvantaged in terms of having no market clout. Individuals are certainly one of those groups, and I think very small groups as well. So I don't know if it's all groups of under 50. I probably would start in our state at groups of under 10, where there's not expertise, there's not market clout. They're very disadvantaged in the market. They pay really high premium rates. I think that they would benefit enormously from having some large and organized purchaser whose responsibility and charge it was to try to keep health insurance affordable for them. And I think we have a very good shopping experience in Massachusetts. So I just don't see, I think there would be a lot of value in having more standardized products. And one of the things that we're going to do and the federal law will require us to do is to allow a small employer to come to our exchange, pick a level of benefits. So say they pick a silver plan, and then the individual workers within the business will have a choice of different health insurers. So some of them could join Blue Cross and some of them could join. So I think you could both produce more affordable insurance for people, and you could give more choice to individual employees within small businesses. So I think that, I think there's a lot of value that the exchange can add there.
Jumping to a different topic that you touched on in the first half of your time with us. You talked about the variation in hospital prices, and you talked about brand or geographic monopolies are higher. And either in your perfect world scenario or in what you're working on currently, how do we you can beat up the insurance companies all you want for what hospitals or providers do. At the end of the day, they're just holding the gambling card of the risk for another entity. How will Massachusetts manage this curve? And do you have any thoughts on how we could?
Well, on the provider monopoly issue, my own preference would be to move towards a more regulated system of hospital payments. I think we have, in almost every area of our state, no market, and so I don't think we should be relying on negotiations between individual provider systems and insurers to determine prices. There's some sentiment for more regulation in Massachusetts. It's not the dominant sentiment, and we have strong hospital systems and politically powerful ones. I think if we look across the world at health systems and which ones effectively control costs, that they're the systems which have organized structures and they don't rely on private negotiations. They figure out what they want to pay, they set budgets, and then the health system is structured within the budget. So I think a budget-based system, all the evidence shows to me, as somebody who's lived in 3 other countries and has this as an area of interest. So
that's the root?
Yeah, I think it's a budget-driven system. You decide how much you want to pay, and then you structure the system under that. But I suspect I myself will have to move back to Europe before I ever live in
You can come to
a
Vermont.
country that has that. But that's one of the reasons why I think many of us are very excited about what you're doing in Vermont.
Is that true like in Germany, Switzerland, France, and England? Is that true through both different types of European?
I think the one universal trait, and those 3 countries have really different systems. So England has a national health service, Germany has competition among sickness funds, France has kind of a hybrid, is that they have budgets, that they decide how much they want to spend on healthcare, and they have mechanisms of enforcing that. So they don't let spending at the end of the year be the result of market forces and private decisions. We're the only country that does that.
And what, like when in Massachusetts, do they have advertisements for hospitals on television?
Oh, yes.
Because during the Super Bowl, there were 2 on hand surgery at Fletcher Allen.
Yeah, I know.
And I think Anya put them in my television.
Yeah.
Now, I'm not accusing her.
Have you ever been on hold with Fletcher Allen?
No, but I literally was like, I was sitting there watching the Super Bowl, no one else, I was like, that 20 people in my living room, and no one else got the joke, and I'm like, Anya,
No.
she somehow got in my house and stuck this into my satellite.
No, everybody's advertising. I mean, Massachusetts, they're all advertising their orthopedic practices, their
Cardiac
surgery
care, Fall
practices,
River.
their gamma knives. We have medical arms race, and other countries don't have that. And we pay higher prices in the U.S. for every single thing, every pill, every day in the hospital, so.
Any other questions? Yeah.
2 kind of big questions. One is, what would you have done differently? Not you particularly, but for the situation that your board is currently in? And secondly, if you could give us more advice, now that you've done such a nice job of not giving us advice, tell us some things, some observations that you think you haven't mentioned so far that we better be considering.
So what would we have done differently? As a board or in terms of the structure of the law?
No, just for you, the board, the law is the
I would
law.
probably sworn less at certain board members.
Did you guys really have that type of open discourse?
Not in a public meeting.
No, I mean,
Well, actually, in one public meeting we did.
I remember.
really?
Yeah.
The meeting.
What was the
I
subject?
didn't swear.
What was the subject?
I don't.
It was just you and Gruber were
Yeah, we were.
intense about your feelings about the particular topic.
Yeah.
That's probably good.
I think, then it must have been around the affordability
think
schedule.
I think it was not doing an increase because of his concern about people dropping out of the mandate.
No, he wanted to link it to premiums.
You wonder what?
So we have a recurrent issue every year, so we have to develop this affordability schedule, and every year we have to revisit the affordability schedule. And so the issue always is, should we increase the amount which people have to pay to comply with the mandate, or should we not? So the argument that we have every year is one member of the board thinks we should increase the affordability schedule by the increase in premiums. So if premiums are going up 10%, then the affordability schedule should go up 10%, which requires you to pay a higher proportion of income every year. I think that's ridiculous. And I think if your income hasn't gone up, then the amount that you spend for health insurance shouldn't go up. So we have a rather tiresome argument every year, which
But
one
that
year.
gets back to my point about there's affordability here
Right.
and then there's
Right.
overall
Yeah,
affordability.
yeah.
But is there at the root of your affordability index, is there like in Switzerland, there's a percentage that you can possibly
Yeah.
pay of your income?
Right.
Did you base it upon like 8% or 6% or?
Ours is a sliding scale, so
Yeah.
it ranges from 0 to about 10% at the highest income.
Yeah.
It's not continuous, which is a nice change that the federal government will make. So we have income bands,
Yeah.
but it's progressive. Yes, it is progressive.
Okay.
We took you off answering.
Yeah,
Karen's
so-
Yeah,
question.
I'm sorry.
What would you wish that had been done differently in your situation, and what would you actually advise us?
I think our board really has worked well.
There were
Yeah,
there were
no,
a couple
please.
of times when the outside pressure forced the board to change their decision that they were going to make.
That wouldn't happen to us.
No, but it was, advocates coming in, other people coming in, that, if you were
Well-
going to do a certain vote or.
Well, no, I mean, I think that advocates have been very effective.
Wait
I
till you
know.
see how long it takes me to get over the Patriots losing.
Anybody got any Kleenex? Yeah.
I always bring them.
Yeah, and I think the board's actually worked remarkably well, actually. So, but, again, we've worked at it, so, as I'm sure you all are too. In terms of what I would, I hope that you will really aggressively use rate review, since that's what you invited me to come up and talk about.
As your
and-
number one choice
No, my number one choice would be budgets.
for hospitals?
Well, for
The whole system.
the
The
system
system.
as a whole. I don't think we will ever make healthcare affordable until we move to more of a budget-driven system. We have to decide, what do we want to spend on healthcare? And then that's what we're going to spend. And if we just let what we spend at the end of the year be the result of, then we'll just spend more and more and more and more. So,
We're in the process of pegging our hospital costs to economic indicators, and feel that, at least coming out of the gate, that this is working pretty well. How would you equate that to the rate setting side? Or could it be? Can you connect the two?
I'm using rate setting in sort of a general fashion.
I see.
And I was a baby hospital rate regulator before my hair was gray a long time ago. I think that's a very clunky system to go in on an individual hospital by hospital basis and service by service basis. So I think it's important to have some structure where you set budgets of some kind and you make societal decisions about how you're going to spend the money. I think the more you can do that on a macro level and let people below figure out what the best allocation is, that's better.
This is pretty much the approach that we're taking.
Well, I think it's great.
Yeah.
So my recommendation would be full steam ahead on that approach. I think you just, if you can make that work here, I think you'll just be a very important example to the rest of the country that's an important way to control costs and that it's doable.
And between, we have sort of 3 pilots at the moment, 3.5 pilots, but around payment reform, 3 pilots. 2 of them involve global budgeting of a sort. One is to basically negotiate with hospitals around a global budget, maybe for a couple of years, something
Yeah.
like that. The other one is to start at the population and have a system, take a per member per month
Yeah.
or some other way to build up what their costs are, and that's what they get, and then they manage the health overall. So between those 2 budgeting approaches, would you feel that one might be a better way to go than the other?
Theoretically, I like the second better. That's a population-based approach. I think you are probably in the early stages of figuring out how to do either approach well.
Right.
And so my inclination there always is experiment with both and see what you learn from that. But I think countries that do this more successfully have population-based approaches and not provider-based approaches. So, and that's my public health heart too. So.
Other questions for me? Any questions or comments from the audience? Yes, Deb.
Yes, thank you for this wonderful presentation, by the way.
For the record.
My name is Deb Richter, and I have a question. First of all, how many people are buying insurance on the exchange? And secondly, have you seen, sort of, since you've implemented reform, any slowing of the velocity of the healthcare costs in Massachusetts?
So the exchange has about 220,000 people, the vast majority of whom are in the subsidized plan.
So do they include your Medicaid? Is that?
No, so people buy through the exchange. So there's a program of subsidized coverage for people with incomes up to 3 times the poverty level.
It's roughly equivalent
like
to
our
Catamount. It's like Catamount.
Okay.
And those people pay a sliding scale premium, so it's free for people with incomes below 150% of poverty, and it goes up to about $120 or so for people at the highest income level. And they enroll and they have a choice of 4 or 5 different private managed care plans, depending on where they live. And that program has about 160,000 people in it. And then there are about 40,000 people, nearly 50,000 people who buy individual coverage through the exchange. Then we're about to add back onto the exchange a group of legal immigrants whose coverage was reduced as a result of state budget problems, but our state Supreme Court has just ordered us that we have to bring them back into the Commonwealth care program. And then there are about 6,000 or 7,000 small people who work for small employers.
And the second question was about the slowing the velocity of
Well, I mean, as is happening nationally, our healthcare costs over the last 6 months have slowed dramatically. And there's a lively conversation going on in our state about why is that. It's very clear that some substantial proportion of it is because of the recession, and we're seeing an overall slowing of healthcare costs. There's also some attribution of some portion of it to the fact that we've really tightened up on rate regulation very publicly, and that there's more and more pressure because of the evidence that we have about disparities in payments and things, more and more that's enabling and empowering and forcing health insurers to negotiate more particularly with highly paid providers. So we've had some very highly publicized renegotiation of some of the contracts of the providers that were on the right side of the bar. And I think that's having some effect at moderating
So do you feed
premiums
that
as
to the
well.
media? Is that how that gets out?
I'm sorry?
Does your committee feed that to the media through your PR?
Whenever we, so last year in our subsidized program, we had flat premiums. So when we are successful at doing that in negotiating, yes, we publicize that
Okay.
very dramatically. We've had much lower rates of increase for our individual coverage as well. So yes, we take full credit for that, even if it's just the economy. The overall trends in healthcare costs, so our governor's taking, I wouldn't say he's taking credit, but I think there's no doubt he's really used the bully pulpit of his office to put a lot of pressure on the health insurers. And yeah, I think the administration is claiming some credit for that.
And the insurers have publicized individual contract renegotiations.
That's right. Yeah, there's a lot of, we got tough. Instead of giving them 5%, we gave them 2%. And, there's very much, I would say, a very changed environment over the last year or so in terms of that. And I think it's all been fostered by
Georgia and me leaving.
Yeah.
That's probably
That's exactly
true
what it
too,
was.
and the very high utilization that you brought with you. But I think it's the public processes, the pressure on the insurers, the small businesses in our state in particular have been wild over rates of increase. And so they've been putting a lot of pressure onto. So yeah, it feels very different. And whether that's sustainable or not, we'll see. But it's a very different environment at the moment than it's been before.
Thank you.
Richard had a question.
Two questions, if I could. One, I'm Richard Slesky. I'm the Director of Payments here in Vermont. And one question is, as we see this utilization and expenditures declining, and savings achieved in effect by dollars not spent, you're commenting on the pressure on the premium increases, but can you as a rate setting agency or an organization that's looking at these rates make this connection between these achieved savings and reduction in premiums or the rate of growth? The actuaries tend to be more conservative and say, well, this is just a one-year event, and so we've still got our trends that we've got to follow. Are you able to push back on that?
So we've definitely seen within the exchange reduced rates of increase or moderating rates of increase among some of our plans that have used some of the higher priced providers because of the renegotiation. That's very, very clear.
Yeah.
And we have authority to go in and look at provider contracts too, which we've been doing as part of our re-procurement process. So, we have at least different plans, more and more using different configurations of providers. So we're moving towards more limited network plans, at least within our subsidized program, but we can see really dramatically. The other thing we can see is a couple of the plans have last year dropped very highly priced providers from their provider network, and the rate impact was actually extraordinary from doing that. And it's wasn't just in the rates that they proposed, but now that we have years of experience, it's actually had even more of a dramatic impact than we expected it to.
So that connection is being made.
Absolutely. Yeah.
And my other question is, in the Republican debates, Massachusetts is characterized as a very high-priced, the highest in the country, and the whole health plan has been a failure.
You shouldn't watch that stuff, Richard.
Are you responding to that? Yeah.
Well, I think it's, we've always been one of the most the high-cost states.
Right.
That was true when Governor Romney was the governor, and it's true now. It was true before Governor Romney became the governor.
Governor Romney.
So,
Yeah.
I think it's been true. I don't think that it's the result of reform, because it long predated reform.
Right. But, are you
Are we
able
trying to respond?
Yeah.
I have a cabinet full of all of the letters and op-eds and other things which people in Massachusetts involved in health reform have written to the Wall Street Journal over the last 6 years, not one of which has been published.
Really?
Oh, no, it's been, so. But I think this is not a debate that's being informed by fact. It's a,
Well, I know.
it's a debate that's being informed by
That's my point,
ideology.
yes.
Oh, yeah, yes.
We'd like to get some facts out, which would be helpful.
Yeah, well, we try, but,
All right. Yes.
Thanks. I'm Janet Kahn. So you had a slide on the question of what percentage of healthcare costs should be invested in primary care or something like that. And there was a state, Massachusetts or Rhode Island, I don't remember.
it was Rhode Island on the far,
On the
yeah.
left, where they were trying to move, they had set the goal to move from like 7 to 11.
Yeah, it was at 6 to 11, right.
So it seems like a reasonable goal if you're trying to figure out what maybe you can do in a year. But the real question of what percentage of cost ought to be in primary care is a huge question. And it has to do, I think, with how important we think primary care
Right.
is and whether we think all of prevention and health
Yeah.
promotion happens within
Yeah.
that and what
Right.
that's going to do
Yeah.
to the drivers.
Yeah.
And there's also the question of what aspects of it you control, because to some extent we're loaded with specialists and not so many primary care docs because we incentivize specialization. So here's my real question to you in Massachusetts or for us, and that is, what aspects of what goes into the cost, the relative cost of primary care, or the relative weight of primary care, you actually have any control over. And then apart from a single year of trying to move from 6.5 to 11, what do you watch and what are you watching? What are the metrics over a 10-year period that would help you really decide whether in fact we should be more like England, which is not ranked as 37th in the industrial nations on health quality? You might know something we don't know.
Yeah, we are 37. England doesn't, on that particular survey, didn't do so well. No, I think it's 20.
All right, so that's important to
Six or
know.
something.
So maybe then money's not so well spent.
No, so the slide I showed was data from Rhode Island. So
So
they've set an
Yeah.
explicit goal to move towards 11% over the next 4 years now. Chris Kohler's going to come when?
We're looking at early
March.
April right now.
Early
Oh, April.
March?
March or
Soon.
April, soon.
Okay, so Chris Kohler, who's the
Before long.
insurance commissioner in Rhode Island, who's involved in setting that goal, is going to come and speak to the board.
Try to be here. Yeah.
And so he would be much better able than I to talk about what's the process and the thinking that they went through.
So is that
to
not
go to
a
the
question
11th.
that the
No,
Massachusetts Health Committee
no.
addresses? You
No,
don't-
no,
well,
we
you're trying
haven't.
to
No, we haven't, so whatever I
apportion.
respond would be woefully ignorant and inadequate, but Chris will give you good advice on that.
Thank you.
Anyone else? Walter.
Walter Carpenter, Vermont Workers Center. Just a quickie about the exchanges. Do physicians have the opportunity to say, no, I don't want to be in them, like in or out of network? Or they have to be in them no matter what?
Well, so the way that the exchanges work is they're just a distribution channel for private health insurance. And so on our exchange, we offer, depending on the program, up to 7 different health insurance companies and then different products by each insurer. So whether physicians participate or not in those products is a result of private negotiations between the physicians and individual health insurers. So we don't contract as an exchange with any providers at all. We just contract with health insurers that have a
I'm just
contract.
curious, as a patient, I had a lot of problems with networks. So
Yeah.
I was curious.
So we have some plans that have very broad networks, and we have some plans that have very limited networks. And in every part of the state, people have at least 3 or 4 choices of different health insurers. So there is choice for people. One of the things that you can do when you go to the website for the exchange is you can look for, if you're looking at a particular health insurer, you can search on individual physicians or hospitals or other clinicians and figure out whether the doctor or the hospital you're interested in is in a particular plan. So I think it's actually made more up-to-date information much easier for people to get. Just with about 2 clicks, you can see a whole range of things, and you can search in a variety of different ways. So I think the website's actually one thing that our exchange has done really, really well.
All right. Anyone else? Oh, Thomas, of course. Thomas always has to ask the last question. It's just our comic relief.
Okay. The camera is taken off for a minute. I'm ThomasHall with the Vermont Integrated Healthcare Committee, and I want to ask a question of where primary prevention falls into this whole category. We spend something less than 5% of our dollars on prevention, and a lot of it, primary prevention is preventing the birth of a disease. And also being a scientist, I know there's a lot of evidence that outside of the conventional system, there are healing technologies that actually have evidence that they can actually not just keep the rate of increase increasing, but to actually make it go down. So I'm partly trying to get the paradigm shift to include thinking not just how are we going to reduce the rate of increase, but how are we going to actually make healthcare costs go down.
Okay,
because it's obvious that healthy people don't utilize healthcare costs, healthy utilizations.
You know, as a public health person, all I can do is applaud.
Did the bill pass in Massachusetts? There was a bill in this year, wasn't there, that would dedicate a certain amount of funding to public health?
It hasn't, but it's still under active consideration. And so it's being pushed aggressively by the Mass Public Health Association, and actually supported by a very broad range of groups. So, but we're arguing over the funding mechanism at the
And
moment.
what is the proposed funding mechanism?
An assessment on health insurers.
Anya,
George's fingerprints. All right. Anyone else? Nancy, thank you so much.
Thanks for the invitation.
Thank you.
Great.
Thank you very much.
Thanks for your time.